Okay, we're going to go ahead and get started. And it's my pleasure to introduce Dr. Schutze. Dr. Schutze is the Vice President for International Medical Services with the Baylor International Pediatrics Initiative, otherwise known as BPI. He's also the Vice Chairman for Educational Affairs in the Baylor Department of Pediatrics. He's passionate about pediatrics, about global health, and about education. And with these qualifications, he's going to give us an exciting talk entitled Responding to a Call in Action, the Pediatric AIDS Corps.
Good morning. I'd like to take the next 25 minutes or so and just kind of tell a story about what we've accomplished over the last 7 years, but specifically the first years of a program called the Pediatric AIDS Corps. So at the conclusion of the talk, I'd like for you to know about the impact of HIV and AIDS in South Africa or Southern Africa. Describe the PAC, as I'll call it. Recall items that the PAC has impacted and discuss the benefits of the Global Health Corps. As many of you know, I probably don't need to really talk about this a lot, but HIV continues to infect and be problematic in people around the world. Most recent data showed 34.2 million people living with HIV in 2011, of which about 300,000 or 2.5 million were kids less than 15 years of age. And sub-Saharan Africa represents about 70% of what we see in the world with HIV and AIDS. This is just kind of a chart from more recent data in 2010 looking at children receiving antiretroviral therapy versus children needing antiretroviral therapy. And when we started this project about 7 years ago, it was about 4 to 5% of those who actually needed it were getting it. Now worldwide we're about up to 20%, 25% in these hard-hit areas. New infections peaked of HIV in about 1997 and have continued to come down, where deaths peaked about 2005, 2006 and started to come down. So those are good data and we're happy about that. One of the hardest hit countries in the world is a country called Swaziland, and I just want to use this as an example for you to really try to demonstrate what we're talking about there. Swaziland, if you don't know, is between Mozambique and South Africa in southern Africa. It's a very small country. You can drive across it in about 4 to 5 hours without complication. It's the only country on the African continent that's still ruled by a monarchy. He has absolute power. He has about 14 wives, and he sustains all the wealth in the country. These are data from 2006 looking at HIV prevalence and age groups in the country. And you'll notice that about 5 to 6% of children 2 to 4 years of age were infected, all the way up to, as it continued to rise, to 49% of women at about 20 to 24, and it peaks in men at 46% at 25 to 29 years of age. Even by 60 years of age, 13% of men and 7% of women were infected. So I'll say again, at 25 years of age, half the women are infected. Almost half the men are infected. And that was 2006, and they haven't repeated this data since then. But so let's compare. Let's do fun with statistics for a minute, and this is not very accurate, but you'll see where I'm going with this. Swaziland has a population of a little over 1 million. Texas has a population of about 25 million. The prevalence in Texas for 15 to 49 years of age is 0.25%. The prevalence in Swaziland of 15 to 49-year-olds is 26%. If you use the most recent data from the Kaiser State Health Statistics, you'll see that people living with HIV and AIDS in Texas, there's about 63,000 currently, of which about 23 of these are less than 13 years of age. If you look at Swaziland today, there's about 185,000 people living with HIV there, and about 14,000 of these are children. If we do simple ratios, that would mean if we had a 26% prevalence here in Texas, we'd have about 3.8 million people in Texas that were infected with HIV, and we'd have about 280,000 children that we were taking care of in HIV. So you see how that affects your population, your demographics. This is the biggest working group of people you have. It affects your whole country, the infrastructure of your whole country. Antenatal clinics in Swaziland, they quit doing surveillance in 2008. In 2004, they were found to be about 43% of women delivering were HIV positive. They celebrated the fact that they dipped below 40 in 2006, but when it rose again above 40%, they just kind of quit doing it. So they haven't tested women there in quite a while. So almost half of all women delivering in Swaziland are infected with HIV. So many places, are really devastated by this illness. In 2005, the Institute of Medicine called for the development of a global health corps, a federally funded global health corps that would act like the Peace Corps, where you would have salary reimbursement, you would have loan repayment, and then it was a tweening process. Physicians would go from the United States, be there for a while until you could scale up education for local individuals, and then leave. This was not funded by the U.S. government. In 2007 then, Fitzhugh Mullen, in an article out of JAMA, again called for the same thing. Now, Fitzhugh Mullen was a family practitioner who was also on the Institute of Medicine called a couple of years before, but again called for this same thing, the development of a global health corps that could go into hard-hit areas, whether it's HIV or other, and deliver medical care. You may be more familiar with this call for action again a call for a global health corps that came out in 2010 by Vanessa Bradford Carey, John Kerry's daughter, and Paul Farmer. And this one's finally got a little bit of traction. But what I would like to do is tell you about our program that we started in 2005-2006 based upon these calls for the development of a global health corps. We developed a global health corps and kind of walk you through how that's gone to date. So on June 27th of 2005, we announced the development of a global health corps that we were going to call the Pediatric AIDS Corps. It was open to pediatricians, family medicine, internal medicine physicians, a minimum of 1 year assignment to one of our sites, and we'll talk about our sites in a minute. We would have training in HIV and tropical medicine prior to leaving Houston. You would have loan repayment up to $40,000 a year. You would receive a stipend of about $44,000 a year in addition to salary, and we would pay for your housing and travel, etc. The loan repayment was paid for by Baylor College of Medicine. The salaries and programmatic support was by Bristol Myers Squibb Secure the Future Foundation. It was a 5-year grant. So really what I'm going to talk about is the first 5 years of this program from 2006 to 2011 when Bristol Myers Squibb quit funding this program. This is their first group of doctors that went abroad for us. There were 52 physicians. I'll call your attention to these two people right here that you may have heard talk already this morning. Dr. Saeed and Dr. Kim were both in our initial group of that. And if you heard about their Tengate work they've done in Malawi, it's pretty awesome. And this is where they started. So the goal of the Pediatric AIDS Corps was pretty simple. It was to provide primary pediatric and HIV care and treatment directly to at least 80,000 African children and families, to dramatically expand access of children to HIV care and treatment, and to train hundreds of African professionals in the care of HIV care and treatment. You may not know that HIV medications rolled out on the continent of Africa to the public in January of 2005. And in all the government rollout processes, very few included children. And the reason for that was that children didn't work, children didn't pay taxes, and we had the Minister of Health from Swaziland flat out tell us that it was okay because children could be replaced. So our goal was really to provide access to kids. That was our main goal that we were doing. During this time, we've built a number of centers in Africa. These are called Centers of Excellence. They're locally staffed by physicians. Excuse me, let me go back. They're locally staffed except for physicians in countries where physicians were not available. And that's what we augmented with the Pediatric AIDS Corps. Some countries have been very successful. Our center in Uganda has been very successful with local physicians from day one. Our main center that we've used for our Pediatric AIDS Corps has been Botswana, Malawi, Lesotho, and Swaziland. So these centers are very robust. They're very well staffed. They're very well supplied. And they provide excellent care to the children and their families. Dr. Klein, who started this, his whole kind of philosophy is that these children should have access to the same type of facilities that anybody in a westernized country should have. And that's what these facilities were built as. We have a very basic rudimentary lab that was there. We have no x-ray that's there. But we can do CBCs and chemistries, et cetera, that are there. So from 2006 to 2011, we had 128 physicians come and work for us in the Pediatric AIDS Corps. As you can see by the demographic breakdown, the majority are women. So it's interesting because when you talk about getting people to work in resource-limited areas in the United States, one of the first things they say is, well, in pediatrics especially, so many pediatricians now are women. About 85% of our training program is now women, that they won't go to resource-limited areas to work. They won't go to the Mississippi River Delta. They won't go to Appalachia. They won't go to these other places. Well, I don't know about that, but they certainly go to South Africa and Southern Africa. You can see the breakdown of our specialties. The majority were pediatrics, but medicine, pediatrics, family medicine, internal medicine. And about a third or two-thirds had just finished their training. That means one-third has come out of private practice. And many people left lucrative jobs to come make $44,000 a year to work for us on the continent. These people are very educated, and they're really pretty neat when you look at their CVs with what they've already done as they apply. About 20% have had masters in public health or masters in science. We've had MD, PhDs. We had about 8% come that already had pediatric subspecialty training, most commonly in HEMONC, ID, cardiology. We've had people that had diplomas in tropical medicine, former chief residents, AOA, former Peace Corps members, and former Doctors Without Borders members. So it attracts a lot of varying people with varying backgrounds. Where do they come from medical school-wise? They come from all over. So this is the number of medical schools. Most commonly seen was Baylor College of Medicine from medical schools. But you can see there's a smattering of medical schools from all over the country and all over the world. And when we look at residency training, it's the same as well. So we always had this kind of UC San Francisco, Columbia University rivalry, kind of this East Coast, West Coast, Tupac, Biggie Small kind of thing go on. And it's interesting is they didn't really get along with each other because they did things very different, and they would always talk about, well, that's a Columbia guy or that's a UCSF guy, but it works in the end. So both these programs have very good global health programs, as does University of Washington, et cetera. But again, we took people who have trained all over the world as part of our initial groups of pediatric AIDS score doctors. Almost 70% came in with loans. The mean loan debt was about $120,000 per person. In the first 5 years, we completely paid off 26 or 30% of those loans while they worked for us. So it was up to $40,000 per year that people worked for us. The mean duration of stay in Africa was 22.7 months for everybody. So almost 2 years. And I'll tell you that this outlier, this 8.83 months is really an outlier. This is a gentleman who had finished his program and been diagnosed with a renal tumor, did his initial treatment and then came to work for us, and then he relapsed while he was there and had to leave. So that's really, otherwise it would be at least a year for people to stay. This is an example of some of our doctors. Cicely Waite was in Tanzania. Megan Harkless was in Botswana, China, and Lesotho, and Amy McCullum was in Swaziland. So where did our doctors work these first 5 years? And this is just a list of countries they worked for at least a month or longer. So our main centers that our doctors worked in are Botswana, Malawi, Lesotho, and Swaziland, with Tanzania being added kind of the last year that they were there, last year and a half or so. We had a program in Burkina Faso that we worked in West Africa, but we weren't successful in scaling it up right, and had to leave about 4 years into the program. We started out placing doctors in China, and we're going to have a presence in China, and it became impossible due to government corruption, so we had to leave and place those doctors in other countries. Ethiopia is a little bit of a different program. It's sponsored to really scale up medical student education and resident education at a Gondar Hospital medical school in Gondar, Ethiopia. So the doctors here don't do HIV, they do general peds, but really help teach a lot in the hospitals. India, we had one person spend 6 months in India. She had worked in 4 or 5 different countries already. She worked with UNICEF and us for about 6 months to go across and evaluate all of India's 7 pediatric centers and give them feedback on their centers. Lesotho and Malawi, again, are our kind of keystone or capstone places. Mozambique, we had a person seconded to the Elizabeth Glaser Pediatric AIDS Foundation in Mozambique that worked there and did a lot of TB work with HIV. South Africa, the same thing. He was seconded to Harvard and worked in Durban, again, scaling up HIV. Swaziland, Tanzania, and Uganda. So really at the end of 2012, I sent out a query for all the people who had finished. It was a 21-question survey, really to ask them about their experience, and I'd like to go over some of that with you. So during the time of this first 5 years, there were 128 members. I sent out 126 surveys. Unfortunately, 2 of our former doctors were deceased. They had died after they left our service. So of the 126 that were sent out, we had 111 return, which was 88%, which I thought was pretty phenomenal to get that. After 2011, we transitioned because of the funding source change from Bristol Myers Squibb. We changed the name from the Pediatric AIDS Corps to the Texas Children's Hospital Global Health Corps. And you can probably figure out where the majority of funding is coming from now. And so they transitioned to the Texas Children's Global Health Corps, 16%. 22% had been gone within the previous 12 months, about 37 for the years before, and 25% had left greater than 3 years before. And I just want to share some of the responses with you. So, did your experience in the PAC affect your career goals when you left? 87% of people said it did, and they usually changed what they were going to do. Many of them, in the second question, did you pursue additional training after working with the PAC? And 52% said they did. The majority of these were pursuing public health degrees, and they were either doing fellowship training with a public health degree or doing public health work at that time. We were pleased to see that at least 56% of people when they left us were still doing international health work in resource-limited areas, but more importantly, 44% were working with resource-limited populations in the United States. We define global health as anywhere children live in a resource-limited area. It could be the 5th Ward, the 3rd Ward, the Delta, wherever, and we were very pleased to see that people were doing that as well. The most rewarding experiences were identified as patient care and program development. People became really attached to their patients, and the most difficult was the amount of death that people saw every day. To give you an example, I had a physician who had trained in Oakland who did a 2-week stint in Lesotho, and I was visiting with her, and she was having problems because so many kids died. In her 3 years of pediatric residency, she had taken care of 3 children that died. In her 2 weeks on the wards in Lesotho, she had 30 children die. And so it was very difficult for her, because literally it would be, she would look at the child and leave the hospital and come back, and their bed would be empty, and nobody would say anything, and the child was dead. So this is the most kind of important thing, or most problematic thing our doctors deal with, is the amount of death that goes on with that. The most important accomplishments really were in the category of infrastructure building, and I'll touch on that in a minute, and then education, peer education and capacity building. What about non-clinical activities? This is a list of the most common non-clinical activities that our doctors participated in. And you can see it's very wide, and it's a lot of stuff that they did that we really described as an unrecognized benefit of the Pediatric AIDS Corps, because we really didn't think about that. It really is a care and treatment process, but people became developed in all sorts of non-clinical endeavors. The policy development, I think, in guideline writing is critical. When you take a country that has 2 pediatricians, for instance, Malawi had 2 pediatricians working in the government service when our Pediatric AIDS Corps doctors arrived, and we put about 10 doctors, 12 doctors, pediatricians there. Then the government comes and asks you to do things, not just about HIV, but for children's health in general. In fact, after we had been in Botswana a year, the president of Botswana told Dr. Klein, he said, "I want to thank you for what you've done to show us that we neglected the children with HIV. But more importantly, you showed us we've neglected all children's health issues." And so, we've helped really bring that to the forefront through this program. It's not all fun and games, though. And so people get hurt, and people have problems when they do stay long in different countries. We've had about 5% had serious motor vehicle accidents. I'm talking about rollovers, and that kind of stuff. Thankfully, nobody's been killed in motor vehicle accidents. As you know, most of the places we work drive on the opposite side of the road from what we're used to, so you have to be careful with that. About 18% have had illness requiring medical attention. 6% required hospitalization. We had one doctor require an appendectomy about 2 weeks after he landed in Lesotho, and he had to go to South Africa for an appendectomy. We've had other issues as well. We had about 6% diagnosed with malaria, and I'll talk about that in a minute. 6% diagnosed with tuberculosis. So we started out of these 128, we had 13 positive people we knew going into it, so 115 people who were skin test negative. So these 7 converted their skin test. from all over the different countries, not just one place. All had negative chest x-rays. All were treated with isoniazid except one who was treated with combination therapy because she thought her exposure may have been multi-drug resistant, and they've all done well. We've had problems with depression. This is the most problematic problem, if I can say it the way that we've had. We actually had to evacuate 2 people in the first 5 years due to psychiatric illness. We had a psychotic break and a major depression that we had to get people out of country with. But the depression is either described some as depression while in country, but a lot as kind of post-traumatic depression when they leave. And a lot of it circles around the amount of death that these people have seen. You are a resource person living in a resource-limited areas. Ooh. And you become a victim of complications of there as well. Was your transition home difficult? Yeah, 41% because they didn't like where they'd been or leaving where they'd been. Are you happy with your decision? 100%. Would you recommend it to a colleague? 99%. The one who said they wouldn't really wanted more of a research project, research experience than what we did because it is a care and treatment program. Let me skip some of this except to show you this. So remember our goal was 80,000 people. By 2011, 80,000 children. We had 103,000 children in care and treatment in our program. So just for sake of time, I'll say that our death rate was about 3.3 per 100 patient years. It's comparable to other programs in the United States and out of the United States. Our loss to follow-up is around 9 to 13%, which is equivalent to what we would see in other resource-limited populations, a little bit higher than what we'd see here in the United States. But this is what you see, and this is kind of addicting. You know, you see patients come in like this, and 6 months later they look like this. Education-wise, we've educated peer education, shoulder-to-shoulder, mentoring, didactic sessions, small group, large group, whatever you want. It's become a very large part of what we do. We've established these outreach sites and did shoulder-to-shoulder mentoring. We're able to graduate sites as far as that goes. And we've been able to increase capacity. So in the 4 major centers that we worked at, Botswana, Malawi, Lesotho, and Swaziland, that had no local doctors, by the end of 2011, 2 of those were fully self-sustainable with local physicians and just augmented with AIDS core doctors, whereas the other 2 sites really required our global health doctors. And the unforeseen benefits I've kind of talked about a little bit. So it makes you think, right? What can you do? So what changes have been named? Well, I told you we switched funders, so we've gone to Texas Children's Hospital Global Health Corps as far as that goes. We added 11 more physicians in 2011, one with a pediatric hematology oncology background. So we're branching out and doing now hemonc, a lot of oncology for resource-limited areas in children. In 2012, we added 22 new physicians, including 1 surgeon and 1 OB-GYN. Both of these are working in programs in Tanzania. This is our 2012 group that left. And so now, if you update the statistics, you can see it's really the same. The majority are women, the majority of pediatrics, but we've added some more subspecialties. And these are the countries we're working in now. So we've included some other countries, Liberia. We're doing general peds work, developing a residency program there. Equatorial Guinea's not on here, but we have a malaria program that's there. And so we've been able to expand. So our goal for the first 5 years of the program was to treat 80,000 African children and families. I think we did that. I think we dramatically expanded access to care and treatment for African children. And I think we trained hundreds of African health professionals. So I think we met our goals for the first 5 years of this program. So Dr. Mark Klein is the brainchild behind this, and he's the one that developed all this kind of infrastructure that you see. We couldn't do it without the directors at all of our other centers and many other people, including Saeed and Maria and other people, and Ed and many others. So thank you very much.
We do have time for some questions. Anybody have a question?
I'm wondering if you had a theory as to why Swaziland had dropped off reporting their HIV
Yeah, that's my opinion. I don't know if that's true or not. I mean, they've just stopped for whatever reason. Yeah, but so if I was writing a book about HIV in Swaziland, my title would be No Sense of Urgency. It just, okay, whatever. So it's very difficult politically in Swaziland because of the king, and because most of the ministers and people high up are related to the king. And so it's just really hard. The AIDS commission they have there is really beats its head up against the wall most of the time trying to get things done. So I can't tell you the real reason, but it doesn't surprise me. Yes. Yeah, so in each of our countries, our major partner is the government. And so if we don't have a good government partnership, it doesn't work. Like Burkina Faso, like China, it just didn't work. If we invited ourselves in and presented ourselves to the government, it didn't work. If the government invited us in, it worked well. And so that's really kind of the key, I think, is we try to become incorporated into the government routine as an extension of the government. It's something that the government can look at and say, they're part of us, and we can help them develop programs and other kind of stuff. But if the government's not engaged, it hadn't worked very well for us. So that takes a lot of time. So we have a gentleman named Mike Mizwa who spends a lot of time in Southern Africa visiting ministers and doing those kind of things. So it just takes a lot of time to do that. Dana?
How do you balance government engagement with the sense of lack of urgency and corruption that comes with it?
Yeah, so the question is about corruption in government and things like that. We're corrupt here too, so it's not like we're not corrupt here. I'm not a very political person, but so, I think a lot of it's personal relationships. You develop personal relationships with these ministers or their principal secretaries. A lot of times it's the principal secretaries that actually do the work. The ministers may be political appointees and may come and go, but the underlings are really what do the work. And you have good people all over, and it just really is developing that kind of one-on-one relationship with them and keeping your word of what you're going to do. If people really see you're engaged and that you're willing to do what you say you're going to do and deliver on what you're going to say you're going to do, they're going to give you more opportunities to work with them.
Since they expanded the program to other areas of
Yeah.
care, are there any plans for expansion into other regions like Latin America?
Right. That's a very good question. I don't know if anybody heard the question about expanding outside of where we are now. So, it's all about money, right? You got to have money to run programs, and so we've developed some new partnerships with some companies you may have heard of. Exxon, Chevron are two of them, and so our program in Angola, which is a sickle cell program, is sponsored by Chevron. They went to the government and said, "Look, we really want to invest in the social well-being of your country. What do you need?" And they say, "Really, we have a problem with sickle cell. We can't diagnose it. People die." You have about 10,000 kids a year born with sickle cell. By 5, you have 2 or 5 that are left. So with Chevron, we've developed that program. We've also recently been to Colombia with Chevron and to Venezuela with Chevron. We recently went to Papua New Guinea with Exxon. And these would be non-HIV programs, but more pediatric health programs. And so we'll see about how that goes. We went into Honduras a few years ago to do HIV work and proposed a program there, and then there was a coup. And so we didn't go. They didn't want us anymore. Yes, sir.
Last question.
On what you're doing in Tanzania.
Yeah, so we have 2 programs in Tanzania, in Mbeya and Mwanza, and they are HIV programs. We have centers in both those cities, and so it's pediatric HIV. We have some partners there, which is why the OB-GYN and surgery 2 physicians are there in Mwanza to go out from Mwanza into the smaller communities and help provide care and treatment there.
Okay. Thank you very much, Dr. Schutze. We're out of time. It's time to break for lunch. Let's give him a round of applause again. For lunch, how this is going to work